Hey class, this is Katina Green, and I'm presenting to you diuretics for pharmacology. So I work with Dr. Harrell to create this presentation for you. I'm going to share my screen. All right, so here we're going to talk about diuretics. It may not allow, okay, here we go. Um, so what we're talking about, the renal system, we're going to pull back on your pathophysiology that you took over the summer. And at that time, we talked about how the kidneys and urethra and bladder work together, and about how urine production and how the kidneys either create concentrated urine or and it regulates homeostasis by deciding how much we're going to put into the urine, right? It helps us by maintaining our pH acid-base balance. It decides how much sodium, water, chloride, and electrolytes that's going to be released at what time. This picture is actually from your book, and the reason it's important is so this is the network inside the kidney. Medications that we're about to review, they can actually work in the distal convoluted tubule. You see where the number 1 is? Shows you how it goes around, and you see the loop of Henle as number 2. And it actually shows you about the ascending loop, and it goes to the proximal convoluted tubule. And this right here is just so whenever you're going over the medications, you can sort of get a visual for those people who are visual learners. And this table actually shows you where it's working also. You see where you have, there's a box over here before you get to the number 1 with the potassium sparing diuretics. And then you got, shows you where the thiazides work. And it shows you where the loop diuretics work also, okay? So we know that the medications we're going to talk about are used to decrease blood pressure. So we're still talking about blood pressure. And it's funny that it's in the chapter that's for urinary, right? Why is that? Because we're using the urinary system to lower the blood pressure and to help us with fluid overload and balancing that. So the conditions that we're going to be working to treat would be congested heart failure, pulmonary edema. The person may have different renal issues, whether it's they're going into renal failure, and so, or cirrhosis. So the person has liver damage and they have ascites. In all of those features, the person can have third spacing. So if we went down the list, it shows you where the person is having trouble. You know, the chronic heart failure. That person may have the pedal edema. The pulmonary edema, that's the person you're hearing with crackles in their lungs and you're hearing fluid in their lungs, right? The cirrhosis, they have the ascites. So you just have to always critically think to pull it together to be like, okay, so what does that mean? So what does that mean? Ultimately, all of these things can worsen hypertension, right? Because ultimately, the heart is still trying to regulate all these problems. So the heart is actually still having to work harder to overcome these issues. The first medication we're going to talk about is the thiazide diuretics. This also is a caption from your book, and so it pulls it together of what we're going to talk about. And so here you have the names, and then you have routes and dosages, and it has the pharmacokinetics on the side. So thiazide diuretics, they're also closely related to an antibiotic, the sulfonamides. That's going to be key because whenever you're talking about a person's allergies, if they tell you that they have allergies to a sulfa medication, it's something you would think about, okay? So the thiazides, they're basically similar. So we're going to focus on the prototype because they all are very similar. Hydrochlorothiazide is the prototype, and it's commonly called HCTZ. And so be familiar with that, and it'll be written in capital letters HCTZ, and that is very common. Again, this is the largest group of diuretics, and that's why it tends to have a little more content to it. What are we using it for? We're using it to treat hypertension. This is one of the medications that you can see given alone for hypertension. It's great to be given. So when you have a person who needs step therapy and they need more than one agent to lower their blood pressure, it's common to see it with two. But this medication can actually be used alone. It can only be taken orally. As we move forward, that is important to distinguish. This is only comes in a pill form. Um, the way that it only comes in a pill form and is not your strongest diuretic. So yes, it helps, it's very helpful, but whenever you have a person who's like stage 1 hypertensive, you can have them on this medication alone. And so it doesn't cause as much diuresis as some of the medications we're going to talk about. How does it act? This medication acts in the distal tubule, and what it does is it increases excretion of the sodium. So sodium and chloride are excreted more. So water follows sodium, right? And so you get out that sodium, and then the fluid goes away. One thing that in the reading that I found interesting that I wanted to pull out for you was they were talking about how evidence shows that taking this medication over time, it can actually remodel the kidney and have a better lower blood pressures all over. So it's just like whenever you start a person on medications, it's like it does some structural reorganization so the patient can have lower blood pressures. And so I thought that was interesting. Another fun fact in here was that even though we know this medication is given to help a person to excrete fluids, when a person has diabetes insipidus, which we also know is a disease process where the person has excessive urination, it can reverse that person who's already having that excessive urination with diabetes insipidus. Interested in your reading. All right, the pharmacokinetics. Again, hydrochlorothiazide is an oral medication. It's absorbed in the GI tract. It is metabolized in the liver, and is excreted in the kidneys. So here we go again, and we're talking about whenever you're reading things and it says use caution with cirrhosis, and it'll say use caution with the person who has renal insufficiency. Well, that is why. Always looking out for where the medication is metabolized and excreted so we can identify a problem. This medication circulates in the bloodstream bound by plasma protein, and its onset is within a few hours. The pharmacodynamics, again, we talked about where does it work. So whenever you think about pharmacodynamics, where does it work? And it works in the distal tubule and the loop of Henle. It works to increase excretion of sodium and chloride by blocking reabsorption. Hydrochlorothiazide does not cause intense diuresis, but most of the sodium, so if we were to go backwards to where the distal tubule is in our picture, you'll see why, where the medication works throughout the system, okay? So contraindications and precautions. You have the severe, renal impairment. So if the person is not producing any urine, the urea, Can we give them this medication? No. They're not producing any urine. So then you're setting, they're drawing it all in, but well, they can't draw it in. Their kidneys aren't working. So that is going to be something that we think about. And like they said, severe renal impairment. A lot of people with diabetes and hypertensive issues, they may have some early stages of renal failure, but we have to be sensitive to those, to the extremes. When you see the adverse effects, so being that this medication, it increases the excretion of potassium, it increases excretion of bicarb and magnesium, right? So look at how this is worded. It's just worded the opposite, and that sort of throws us off sometimes. So adverse effects says that it can cause hypokalemia. Didn't we say the same thing? I said it excretes more potassium. So if my body gets rid of more potassium, wouldn't it mean that it would leave me hypokalemic? It would. So that's what sometimes we get thrown off, and like I said, we got to turn these words around and put it into our own words. An interesting feature of this medication, it decreases excretion of calcium. So looky here. So therefore, it may cause hypercalcemia. Well, of course, we don't want the calcium levels to get to the point to where they are deadly or causing side effects. But how could this help a person with osteoporosis? It could actually help them. So if the person has hypertension and they have osteoporosis, this medication could actually help them build their bone density. So that's something. So whenever you look at your notes and it's talking about, it'll also note that, it is helpful for the person who has osteoporosis. So everything is within, everything is within moderation. From the reading, I also wanted to note that that this medication can increase blood glucose levels, increase lipids, and increase uric acid. So what I would like for you to do while you're taking your notes is I want you to just create a little table that literally says that. So what does this medication increase? It increases excretion of potassium, bicarb, magnesium, blood glucose levels, lipids, and uric acids. Why is uric acids important? You have this vulnerable population who can also have gout. So if you have a person who's on gout and who has gout, and so those, they have the painful joint inflammation, and it can be, it can actually take people out of work and everything. It's a very painful condition. So if this person has gout and we put them on a medication that could increase their uric acid levels, that would be a problem. So we also have to be mindful of that, okay? So when you're looking at the health status, of course, you're assessing the person for allergies and what is the medication that we want to assess them for, the sulfonamides, and a person who's actually had a reaction to the thiazide diuretic. Hold on, let me find my table. So I said assess them for their allergies. You're going to assess their renal status. You're going to assess their liver enzymes. Or be mindful. So whenever, since this is pharmacology and these are the things that they want you to know about, so when I say assessing, it's just being mindful in the aspect of when you're reviewing your medications. We are going to be mindful if the person has gout. We're going to be mindful if they are diabetic and their cholesterol levels. This is a pregnancy category B medication. Yes, a pregnancy category B medication. And lifestyle teaching, of course, we're going to be encouraging their lifestyle modifications and their sodium intake. So whenever they say environment, access to toilet, that may seem simple, but what you have to think is beyond that. As a nurse, you have a patient who's on a diuretic and they're going to the bathroom a lot. And then they have 3 or 4 IVs connected to them. you have to make sure that that they're safe, sure that they have access to the bathroom. Do they have a Foley? Not Are not kind. We don't like to keep them in. So are they going to have access to the bathroom? Do they need to be reassured to call you or to help them get up to the bathroom? But so that's when you see assess access to toilet, you're looking at the person and what do you need to do to make sure they have access to the bathroom. Culture and inherited traits. This is one of the medications that they identify as being very helpful in the African American community. Is that because of the sodium intake that is often found in the African American community? But it has been very successful in the African American community, and they go into detail in the book about this. And I just want to make sure it's not something else before I turn this page. Okay. One red flag, I do want to say a red flag on this medication was that it is not to be taken with dofetilide because the two together can can cause lethal arrhythmias. Okay, so that is also in the book that it is a red flag, a black box warning on this medication. And so, of course, alone being that we do have changes in potassium, we're always going to monitor for monitor for EKG changes for anyone who has potential of having potassium depletion or having excess potassium. I wanted you to, on your own, to look at box 27.2. It reviews factors that may influence noncompliance. One of the things you have to, okay, the next slide, I can talk about that more. So on in the box 27.2, it reviews factors that may influence compliance or non-compliance. In order to help your patient, you will advise them to take it in the morning. Why is that? You don't want them up and down all night using the bathroom. That's going to be one of the main reasons why they don't want to take their medication. When you're inquiring with the patient on why they're not taking it, days is it has them going to the bathroom too much, or they're not sleeping at night because they're going to the bathroom. First question I would ask is, what time are you taking it? And like I said, reviewing that box, I'll go over some scenarios to help you in the future so you won't have some of those pitfalls. So minimizing adverse effects, of course, we're going to correct any electrolyte imbalances and we're going to monitor them. I think we've gone over everything on this page. Something and see if I can plug in. Let's see if this works. Okay, we're going to give that up. So I was going to try my best to plug in one of the Picmonics, but I have too many tabs open, so that's not going to work this time. We're going to move on to loop diuretics. This medication, these loop diuretics work in the loop of Henle, and they basically block reabsorption of sodium and chloride. So it's allowing the kidneys to excrete it instead of looping it back into the system. I like the way that sounds. They are a powerful diuretics. So this is going to be, the person is really going to be going to the bathroom, okay? And when they have to go, they have to go. So it also notes that how they call it a high ceiling diuretic because it does cause so much diuresis. Right. So what does this medication do? Lasix decreases peripheral edema. It decreases pulmonary edema, and it works well in renal patients that maybe the hydrochlorothiazide is not working with. This medication can be given oral or IV. I wanted to note that this is a slow IV push, okay? So when you are given an IV push of Lasix, it can start working within 10 minutes. So your patient will start going to the bathroom within 10 minutes. And 40 milligrams can be given over 1 to 2 minutes. So what that means is you're going to have you're going to slow down your push. So just as a review, whenever we do an IV push, so it depends on the volume, you got to be able to control your volume, right? So then you just say, if your IV Lasix is diluted, let's say it's in 5 cc's. We're going to use this because it's an easy number to work with, right? Or 5 mLs. So then you want to push it over 1 to 2 minutes. So what you have to gauge is, so you got the 5 mLs, and then you have 1, 2, 3, 4, 5. So you may push in 1 ml and then say count to 15. Then you push in 2 ml, you push in the second ml, count to 15. Push another ml, count to 15. So so by the fourth one, you counted to 15, 4 times? So that's 1 minute. But it actually probably took you a little bit longer because you still had to push it in between that, right? So you see how that could be 2 minutes? That's how I control my pushes. I don't know if someone else in fundamentals taught you a different way, but to me, that's the easiest way other than me staring at my watch to see how long it's been. The best part about it is you're not pushing it too fast. It's not, it's not like you're going to be there 10 minutes. So if you just do 1 ml, then count 15, another ml, count 15, you'll be great. This medication is highly bound to protein. It is, again, metabolized in the liver and excreted in the kidneys. Go back to the oral medications. I wanted to note that it may cause GI distress, so it would be nice to give it with food or milk. The pharmacodynamics, what it does is no, I think I already said it. It blocks reabsorption of sodium, chloride, and water. And it works in the ascending loop of Henle. Thus, so in order to do the elimination to the kidneys. So I would like to highlight that it works in the ascending loop of Henle, okay? Oh, go back here. So what I wanted to recognize is how this was different with the hydrochlorothiazide. There's no mention of calcium here, right? There's no mention of calcium. But what I did find in the reading also was that this medication actually excretes more calcium. So in this patient, they would be more at risk for calcium depletion and bone deficits, okay? So that's what I found in the reading. But whenever we're going to write down, if we were going to create a table of if we're going to create a table of to separate how it works or what reactions it has, I would make a little table. This is actually what I did when I was reading. Actually, I'm looking at it. I said that this medication increases blood glucose levels, LDLs, total cholesterol, and triglycerides. What does it, so, and then what does it decrease? I have on the other side, I have it decreases uric acid, and we already talked about uric acid, right? It decreases bicarbs, and so whenever you have a reduction in bicarbs, you're always at risk for metabolic acidosis, right? So I just wanted to make sure we covered that. Cautions, here we have the anuria and hypersensitivity to this medication. I also put on my notes for caution in renal disease. We know why. Liver disease, we know why. Allergies to sulfa, patients with lupus, and also be mindful that this medication can cause ear damage or ototoxicity. I thought I saw that. It is right here. So here briefly, it has electrolyte imbalance, oxotoxicity, and alteration in glucose levels. So it's the same thing. And so, like I said, keep in mind when two things are saying the same thing, but you say it in different words. Because translating evidence, remember, you got to read what it says and translate it back. So no matter how the test question is answered, you've translated it so you can understand and deliver that material back. Patient variables, I think these are things that we've already covered. Maximizing therapeutic effects. So this is a medication. You're not going to start them off on the max dose. You're going to increase them to see how it's tolerated, right? We already talked about how it's a slow IV push. Oh, and it's written right here. Administer 20 to 40 milligrams IV push slowly over 1 to 2 minutes. And so that's a review. The teaching is going to be just like the teaching for the hydrochlorothiazide. All right, those are our big meds. So now we're going to move on to the triamterene, which is an aldosterone antagonist. So this medication is a mild diuretic, and it's often used as a potassium-sparing diuretic. Don't forget that. That's the key to it. That's the whole category, is potassium-sparing diuretics. This medication is often used in combination with another diuretic for this reason, because this medication can counteract. Like, so you're giving them this Lasix that and can deplete their potassium. So then you may give them this, they may be given this medication to try to save some of the potassium, okay? So it's often used in combination. This medication has multiple off-label uses. The book notes acne and male hormonal suppression. This is also often, no, not often, it's whenever you have a transgender person, a transgender male to female, they will be on spirulactone to help them with the hormonal differences. Um, so here again, it causes weak diuresis, but it does have other properties. All right, I'm gonna move on. Moving on. Hold on. Okay, contraindications are similar. Um, yeah, so drug interactions, they're noted, and actually that's from a table in your book. Health status to pregnancy category C, so that's what's different. And the rest of them, access to toilet, those are familiar to you. All right, and of course you'll have a copy of this PowerPoint for yourself. Patient teaching would be the same or similar. Osmotic diuretics is our last category that we're going to talk about. This right here is a medication that is not, you're never going to see them. The prototype is the mannitol. This is not a medication that you're going to find with your CHFers, your patients with ascites, okay? These patients are for patients, they may have acute renal failure, and this is used acutely. They may have increased the step down neuro unit. They use it in the neuro ICU. The mannitol is like one of the main things they use, because for intracranial pressure is not used with the active bleeder, but when you have a person who has the intracranial pressure, it is very often used from cerebral edema. It is also used with intraocular pressure. And you got to break down that word. That is for the person who has the pressure in the eye. And why would they have the pressure in the eye? This is the person with the chronic No, no, no. No, so this is just reducing. I don't want to mix. We got one more we gotta go to. So intraocular pressure. Um, so they're not reabsorbed in the tubules. It's more that it works throughout the kidney, okay? So that's different. It's not specific to one section of the tubules. They increase osmotic pressure, as in the name, and it pulls fluid from the vascular space. So whenever you think about the vascular space, it's more specific to the vascular space that's within the brain or within, within the skull. It um, pulls fluid from within the eye. So that's what you're thinking about, is more those smaller spaces, okay? Um, and it also prevents reabsorption of sodium and chloride. And isn't this a reoccurring theme? We keep on seeing that sodium and chloride, right? And I think that's all. And this is that is an IV medication, okay? And like I said, you see this more with acute patients. It's not something that you typically see in a nursing home or a regular med-surg unit. This is more of an acute problem. All right, so this medication here, the carbonic anhydrase inhibitors, is a acetazolamide. That is the prototype that we're going to talk about. And look at how this last one is even more specific. We started off with very broad medications, and now we're just narrowing it down to this. His whole purpose in life is to reduce fluid that can accumulate in the eye. So this person may have a diagnosis of chronic open angle glaucoma. Medication helps to pull that fluid out. Let's see. So this medication, we're going back to the tubules. This one right here it works in the proximal tubule. Okay, they are not used in the traditional way that other diuretics are used, and the medication is used to decrease fluid buildup in the eye. So I think we all covered all that. It's absorbed in the GI tract and excreted in the kidneys specifically, and is processed in the proximal tubule. And I think that is all the highlights that I got when I took my notes when I was doing the reading from the book. And here is some highlights here. So in combination of what I told you and what is on this PowerPoint. If you have any questions specifically, we will give you a date. We're going to do a review, and then you can bring your questions. If you have specific questions, feel free to reach out to myself or Dr. Harrell or to ask. It's no problem. I tried to go through this and make it as, I just really try to go from the book. So really, if it's something that's not clear, you should be able to go exactly to the book, because that's where I took my notes from, is from the book. I did not use any other sources. Some of the areas were smaller than others, but I just stuck with the material from the book.